have independently been able to stop neovascular disease, nor have any of the pathways found to be, when we have found to be incrementally additive to VEGF. In other words, when we turn off the other pathways, the results are no better than anti-VEGF monotherapy. So VEGF consistently comes back as the master regulator. It is essential for choroidal vascular development, and it is the target that we look at in terms of disease control and in terms of improvement in function and morphology.
And when it comes to Eylea, the things that I think help it stand out are its binding affinity first and foremost. The way it's designed is its decoy receptors. So instead of it having to bind the VEGF binds it. And what you get is a much tighter, more effective binding. The half-life has been excellently modeled by Dr. Michael Stewart, and the effect of the half-life as far as durability. And don't forget the ability to bind the placental growth factor, which, although we don't know exactly how much placental growth factor contributes, we do know it's upregulated in these same disease states.
So just to summarize, the pivotal angiogenic and pro-leakage factor in ocular diseases, in ocular conditions, is VEGF, and that's why we are still targeting VEGF with the existing agents and the newer agents.
So when a new drug reaches the market, all what we have is pivotal trials. So that's very important for the drug to be approved, but then we need to have our own experience, and we need data from the real world. Because the patients are not exactly the same, because the compliance of the patients to the treatment regimen that we wish is not exactly the same.
I think it's very important when you see that all the good results that were coming from the clinical trials, you can see it in real life.
So Eylea has been looked at in several real-world studies, and we see that the visual acuity results are up around 6 to 8 letters, which are comparable to those in the phase 3 trials for AMD. For diabetic macular edema, many of them are up to 9 to 10 letters, which once again rival very carefully what we see with the real-world trials. Furthermore, we know that whether we treat with Eylea on a Q8-week basis going forward, or whether we treat on a treat and extend basis, because now we have good data on treat and extend with Eylea for both neovascular AMD as well as diabetic macular edema, we still maintain those excellent visual acuity results over the course of 1, 2, and sometimes up to 5 years.
Nowhere is real-world evidence more important, though, when it comes to safety. And what I greatly value is 10 years, greater than 10 years now, of clinical experience, with it being our first-line anti-VEGF therapy in our practice.
The good thing about Eylea is over the course of 64 million injections, we have extraordinarily low rate of intraocular inflammation.
Why I have confidence in it is because I use it every day and I see the difference it makes in our patients' lives. So we know from studies like Altair and Aries, 2 fantastic treat and extend studies, that in the real world we can utilize treat and extend to customize our treatment intervals to that patient's need. And in the majority of patients I've found, be able to get those patients out beyond that 8-week barrier to more like a 10, 12, and even 16 weeks.
But what was interesting was that we didn't seem to lose patients between year 1 and year 2. Once we established the interval, then patients were maintained. So aflibercept maintained that ability to successfully treat patients between year 1 and year 2. So it doesn't seem to be lagging, or it doesn't seem that its potency diminishes over time. So we have a very effective method of treating patients with neovascular AMD, diabetic macular edema, even vein occlusions on a treat and extend basis.
What I like the most with Eylea is that the evidence is robust. So it helped to change completely the regimen. So now we know that we can extend it, so we feel very comfortable, and we can even detect this profile of patients where we can even extend to Q12 or even Q16.
We are very confident now to go to Q16 because with aflibercept 2 mg, we've seen that it is possible for quite a high proportion of patients. For those patients with aflibercept 2 mg, the burden of the disease is much lower.
I think physicians can trust Eylea experience and, in other words, efficacy and safety because of the large amount of data coming from pivotal randomized trials, coming from real-life experiences, and the two major keywords which I would use for defining Eylea. One is durability, and that's really promising because the major unmet need today in treating macular conditions or retinal conditions is definitely durability. The other keyword which characterizes aflibercept or Eylea is its flexibility. It can be used in a fixed modality, bi-monthly, and this has some clear advantages in terms of logistics, but again, in a modality, in a proactive modality, in other terms, treat and extend, Eylea has proven to be a kind of ideal agent for treat and extend applied to our patients.
Світ без хвороб та голоду. Такою є місія компанії Bayer. Це прагнення, яке поділяють наші працівники по всьому світу. З перших днів повномасштабного вторгнення компанія передає Міністерству охорони здоров'я ліки та медичні матеріали для десятків тисяч пацієнтів. Було профінансовано закупівлю 6 карет швидкої допомоги для лікарень та бригад екстреної допомоги Червоного Хреста України. Крім того, 44 дефібрилятори встановлено на вокзалах, станціях метро та в лікарнях у 18 областях України. Компанія виділила 1,3 мільйона євро для відбудови української інфраструктури у сфері охорони здоров'я через фандрейзингову платформу United24 для ремонту Чернігівського медичного центру сучасної онкології та придбання обладнання для Інституту нейрохірургії імені Ромоданова. Спільно із благодійним фондом Дон Калабрія компанія надає психологічну підтримку близько 3 тисячам внутрішньо переміщених дітей та їхніх батьків, допомагаючи подолати симптоми посттравматичного стресового розладу. Через агресію проти України продовольчу кризу відчула частина населення світу. Небезпека голоду стає ще більшою, і ми робимо все, що в наших силах, аби їй протидіяти та підтримати аграріїв України. Наразі однією із найбільших проблем для українських аграріїв є велика кількість мін та боєприпасів, що не розірвалися. Щоб її вирішити, ми виділили кошти для придбання машини для розмінування, що допомагає очищати великі площі полів, повертає їх до використання та убезпечує водночас наших аграріїв. У квітні 2023-го компанія оголосила загальні інвестиції у 60 мільйонів євро у виробництво насіння в Україні. Bayer відданий підтримці України від початку війни та підкреслює свої стійкі наміри, здійснюючи сміливі кроки назустріч відновленню нашої країни. Україна переживає надзвичайно складні часи. Тому ми продовжуємо надавати допомогу в соціальній, аграрній та медичній сферах і віримо, що завдяки підтримці один одного ми зможемо пройти крізь всі випробування разом до перемоги.
Colleagues, we start our satellite symposium of our partner, Bayer company, that is dedicated to anti-VEGF therapy and diseases of fundus. I want to present you our first speaker, Doctor of Medical Sciences, Professor Karol Andriy Rostislavovich. What should we do if we have insufficient response on VEGF therapy? Today we will talk with you. We have successes in our treatment, but we have no response or it is irrelevant. And we may do 10, 20 injection and we have no result. We have resistance. What is it? So our body, our organism doesn't respond on this treatment. It's not only about VEGF therapy, but the therapy in general. But if we're talking about resistance, we should talk also about pseudo-resistance when there are anatomical reasons not to perform therapy. Here we can see diabetic macular edema, but we have also epiretinal membrane that provokes the effect of this medication, and we need vitrectomy here. Another one patient, another example, central choroidopathy. We can see here the pathway of this disease, and there is also pseudo-resistance because there is no pathological chain, because there is no subretinal subvascularization. Taras Bogdanovich will help you. Another one example of pseudo-resistance, you can see on the screen a very complicated disease. We should use corticosteroids, antifreeze medications here, and it is polypoid choroid disease, and it needs complex therapy. We know also that there is a gene-associated code. There are some genes that cause decrease in sensitivity or insensitivity to some medications due to the macular degeneration. What are the types of resistance or clinical manifestations? These are tachyphylaxis tolerance, structural changes of new constructed vessels, and in other factors of growth. What is a tachyphylaxis and tolerance? What is the difference? Where you can see that the organism doesn't respond on the first or second injection, or this response is insufficient. It can develop after the first injection, but after repeated as well. Also, the efficacy can be renewed if we stop injecting this medication and change the therapy or increase the gap between injections. Here we are talking about tachyphylaxis. What is tolerance? Tolerance is vice versa situation. We see the decrease in efficacy after the second and further injections. So you can see here step by step decrease in efficacy of medication. When we increase doses or increase the frequency, we will have better result. It's about tolerance. What about structural changes of new created vessels? We have mutation in the endothelial cells. We have presented you this information on our workshop, but why do we have such a situation? Because endothelial cell structure can be changed, so-called mutation. Uh, then spare vessels can be formed. So there is external membrane and there are new cells, proliferated cells inside this vessel. And anti-VGF medications are not effective for such vessels. Also, anti-inflammation changes of choroides. And here you can see the list of diseases and manifestations. We know that all anti-VGF preparations are effective against immature vessels. If they are with parasites, no medication is effective on these vessels. Also, we are talking about penetrating efficacy and other factors. What about another growth factors? We know that at first in our clinical practice we find out about VGFA growth factor and prolizumab was used, but when we studied the pathogenesis we covered that in other factors also influenced on it. We are talking about FGF, TGF, IGF-I, PGF, SNTF. We don't have ophthalmological medication to inhibit those factors. If, for example, we inhibit FGF, and other factors can take this proliferative role. Fortunately, our medication, as aflibercept, was manufactured to inhibit several factors of growth. It's not only well-known VGF-A and placenta factor of growth, but VGF-B and halactine-1. We are talking not only about proliferation, but anti-inflammation action of this medication. It covers several pathogenical factors. One molecule has a widespread field of action. In our clinical practice, so yesterday I was posed a question, what should I do with such a patient? In order for you to understand what is the proper clinical picture, you have to analyze your OCT images, talk to patient, but I advise you to use systematic treatment in order to reduce the systematic row of questions. You have to know and to follow the instructions. If there is a gap between injections in 4 weeks, you should follow this guideline and not to make injections in 5 or 6 weeks. So it is crucial to follow those guidelines, even not in 1 month, but in 4 weeks, because if we inject him in Thursday and he can come on Saturday or on Sunday, we will have a delay, and it increases the amount of days between injections. If we perform control OCT in 2-3 weeks after injection, and there is a decrease of edema or lack of edema, you understand that it is effective, and it looks like tolerance, because when we have tachyphylaxia, there is no decrease in edema. These processes and guidelines are universal. Uh, Anatomy is better when we are talking about tolerance. If you have an interval in 10 weeks and you reduce it to 8 weeks, you will improve the thickness of retina and reduce the edema. Increase the dose of medication also will improve efficacy if we are talking about tolerance, but it doesn't influence on tachyphylaxia, and vice versa. When we have mm, special schedule of injection, it will improve the situation with the tachyphylaxia, but will decrease with the tolerance. Now, what about schedule of injections? More than 95% of patients, TNA and PRN, are characterized for tolerance, and tachyphylaxia is normal for fixed schedule. In our practice, we practically don't have tachyphylaxia because when we endure the term of injection, we prevent tachyphylaxia. Characteristical features of our patients with resistance to aflibercept. A very wide amount of previously made injections, from 6 to 14. Some patients were injected only aflibercept. In other different patients, a regimen of treatment were also differs. There were different options. There was no fixed schedule of injections. That's why all these patients are with a tolerance, not with a tachyphylaxia. So, some technical issues. Central thickness of retina before and after change of regimen. When we reduce the intervals, there was thickening of retina caused by tolerance. What is the proposed scheme in regimen, treat and extend, and response to tolerance? We made 3 injections with interval in 4 weeks. Then we make a pause in 8 weeks, and during the 4th injection, we assess the condition of retina, anatomical and functional. If during this fourth visit, of course, we make this injection, if we have good results and there is no edema, high visual acuity, we can endure the interval between injections. And if we see edema, a decrease in visual acuity, we shorten the interval. So minimal interval is 4 weeks, maximum 8 weeks due to the instruction. Then every other injection, before every other injection, we assess the situation and can change the regimen flexible. And we got maximum functional results with minimum injections. In our practice, it's our experience. We made loading injections, then treat and extend regimen. So all the patients are injected in a treat and extend regimen. You know that we have a lot of patients, that's why we use this regimen. In 3 following injections, so we assessed retina. If there is a request, a need, if we see changes worsening, we can reduce this interval up to 8 weeks. If we don't see a positive dynamics, we can suspect tolerance and decide our further roadmap. So it's our individual tactics of patient treatment. Those questions of resistancy were started by the expert board in 2022. It was also the reduce of interval less than 8 weeks between injections of aflibercept in the patients with NVD, and it helps to continue treatment with more longer intervals in future. When we have such a situation that we should shorten intervals, because we have such an experience that the interval was 12-14 weeks, and then we see that the efficacy is decreasing, I tell the patients that we should overcome this situation, and after a certain number of injections, we may prolong this interval between injections. Sometimes it is necessary to have such a practice of decrease between intervals in 1 year and then to come back to our usual regimen. If we are talking about atezolizumab administration quicker than 80 weeks, we should choose another regimen. Aflibercept in treat and extend helps us to choose individual regimen of treatment. Clinical cases: patient 83 years, hidden XNM, previously 5 injections of atezolizumab and 3 of aflibercept. You can see the dynamics after the loading injections. When we are talking about atezolizumab, and there are no loading injections, there was no sufficient efficacy. But after loading injections, When we prolong the interval, the result decreases, so we shorten it again. And when we have a 4-week schedule, we've got the improvement.
Another patient with exudative form, she was 64 years old. She, after administration of 3 load injections, her reaction was really nice anatomically and functionally. With the interval of 8 weeks, he had thickening of the retina. That is why our interval was shortened to 6 weeks and then to 4 weeks. We administered this preparation until the retina attached completely. After 10 injections, we switched the patient to prolonged intervals. It happens both with primary patients and patients who had received other types of injections initially. Another clinical case, aflibercept injections were administered to our patient. Additionally, this patient had detachment of retina. After 5 injections of ranibizumab, the detachment of epithelium was still there. After 3 more administrations of aflibercept, the patient was treated with PRN. 7 injections of aflibercept were administered, and then T&E treatment regime was chosen. After 10 injections then of aflibercept, the different schedule was established. Thus, I can say that in insignificant response to anti-VEGF therapy, we can clarify the diagnosis, exclude anatomic preconditions, make control OCT 3 or 2 weeks after administration to check the condition of retina and see if there are improvements or not. We can shorten the interval between 4 to 6 weeks in tolerance and combine with other methods of treatment like laser, coagulation, or any others. Thank you for your attention. Thank you, Andrei Rostislavovich, for a wonderful report. If you have any questions, you are welcome, please. Photodynamic therapy is a quite difficult treatment method, and in age-related macular dystrophy, the patient should be switched to this method very carefully. Secondly, to perform photodynamic therapy, you should take into account the visual acuity, which does not have to exceed 0.5. If the membrane is hidden, there should be symptoms of progressing of this hidden membrane, because for photodynamic therapy, more acceptable are those patients who have classic membranes, like myopic membranes or classic membranes in age-related macular degeneration. So if corticosteroid therapy does not help, then you may combine it with the other methods which you mentioned. Any other questions? If not, then let us thank the reporter for his presentation. The next report by Doctor of Medical Sciences Umanits Mykola Mykolaievich, anti-VEGF therapy in cases of tear of pigmental epithelium of retina. The topic of my report was not chosen accidentally because during our clinical practice we noticed many cases. Any ophthalmological surgeon probably had similar cases when we are facing the question what to do earlier. So this question is topical for me as well as my more experienced colleagues. If we recollect age-related macular degeneration, then there is no doubt that this disease is so widespread, which is disabling to the stage of blindness in patients over 50 years old. This is one of the most aggressive and let us say it's a form of a disease which causes inevitable changes in the retina. This is like neovascular age-related macular degeneration, which leads to terrible results, terrible consequences in patients. We are using some classifications of age-related macular degeneration. The authors of this particular classification was presented by Korol and Pasechnikova in 2010. So special treatment should be managed in all stages of this disease. This slide shows transudative detachment of pigment epithelium of retina from the Bruch membrane, and if the course, in some courses of this state, 22% cases might lead to geographic atrophy, 45% may lead to neovascularization with hidden formation of hemorrhage detachment of pigmental epithelium of retina. There used to be many approaches to treatment. Like laser coagulation was used really long ago, and laser caused complications and probably damaged more than useful. Then other types of therapy, like photodynamic therapy, were used. And now we are in the anti-VEGF therapy era. Unfortunately, despite all the efforts of the manufacturers of these revolutionary indeed preparations, there are still cases of detachment of pigmental epithelium of retina. If we recollect pathogenesis of detachment or tear of pigmental epithelium, this scheme shows nicely the process as it goes on. The tears are usually associated with detachment of pigment epithelium layer in patients with exudative age-related macular dystrophy. Their membrane starts shortening and pulling the layer of pigmental epithelium. So where the arrow shows, this is the place of potential tear. In accordance of severity, there are four classifications, four stages. For the first stage, the tear makes up less than 200 microns in diameter. Second stage is from 200 to 1 micrometer. Third stage is over exceeding 1 micrometer, and the fourth stage is a tear which concerns also the central fovea. These OCT scans and fundus images and fluorescent angiography show all these four stages. As a rule, patients of the first stage, if the fovea is not engaged into the tear, the visual acuity might not be affected and might reach 100%. The next third stage already has visual symptoms. The view of the tear, as you can see, this tear does not engage the fovea. This is not the most dramatic situation of all, unlike the fourth stage situation where nothing can improve the visual acuity because the central fovea is engaged, and any prognosis as to improvement of visual acuity is unsatisfactory. What are the predictors and risk factors for tear of pigment epithelium level layer? First of all, this is detachment of pigment epithelium layer up to 400 square micromicrons. We always have to keep in mind that this can happen even in case if we use anti-VEGF agents of the highest quality. Small ratio of detachment of pigmental epithelium and subretinal vascular membrane is another factor of development of this tear, as well as micro cracks in the epithelium. For today, fortunately, we have a lot of diagnostical resources which help us act correctly and correctly establish the diagnosis. So by looking at this photo here, from the first sight, one cannot be sure that there is detachment of pigmental epithelium. We might notice some dystrophies, some lesions, but picture B shows another test, angiography with the hyperfluorescence on account of the vessels, and the angiography confirms the diagnosis for 100%. We have to say that we are proud of Andriy Rostislavovich, who is a member of Visual Academy. He's the only member in this organization from Ukraine, which is a huge honor for us. And it's great that Ukraine is presented there. The specialists from all over the world are meeting there and sharing their experience, making powerful conclusions. So one of such meetings concluded that patients with active diseases treated with anti-VEGF therapy in most cases get the most, the highest possible effectiveness. Anti-VEGF therapy in tears of pigment epithelium level from the first to third stage, 5 patients out of 7 had improvement of visual acuity. Have a look at our research concerning development of pigment epithelium tear in use of various anti-VEGF preparations. We had a number of patients with developed tear, and the researches were made by Tinaya and Lucerne, and it was observed that tear repeatedness in the group of faricimab as compared to aflibercept group, the first one was higher. In a small retrospective research, regressive effects of aflibercept and faricimab were studied in cases of detachment of pigment epithelium, and in aflibercept group, the quantity of tears was higher than in faricimab group. But in my opinion, whatever we use, any preparation can lead to detachments or tears. And indeed, aflibercept has been used since a long time. This is the first choice preparation in the majority of cases. The safety satisfies us really much. Rheumogeneity of this preparation is also proper. Aflibercept shows itself well in development of other conditions. Let us discuss some clinical cases. Here you can see a patient with subretinal neovascularized membrane who was having doubts if he needs injections or not. And after a month of doubts and second thoughts, this natural course of development of the disease turned into partial detachment of pigmental epithelium. So like we said, it does not always fatal for the vision organ, but still this patient is still with us, he is still being treated, and let us have a look at his visual acuity on therapy. It's 0.8. This is an impressive result. The patient is continuing to obtain aflibercept. Another clinical case when this patient primarily referred to us with the detachment of pigment epithelium level. This was not the 4th stage, so we started aflibercept injections according to schedule. Here you can see our colleague's case, which is tragic because even despite anti-VEGF therapy, the failure rate does not equal 0. Unfortunately, failures still happen. Sometimes there are consequences in strong hemorrhages and really bad prognosis. I would like to say that in our institute there is a special approach to treatment of such condition. It was published in Taras Bogdanovich's paper. So in order to prevent the tear of pigmental epithelium of patients, it is proper to inject these anti-VEGF preparations into subthenon layer because it decreases the risk of atrophy, of the development of atrophy of pigment epithelium layer. Speaking about prophylactics, me and Taras Bogdanovich a couple of years ago had this talk about how else could we prevent different types of detachments. When there is neovascularized membrane, there is high transudative detachment of pigmental epithelium. There was an idea to administer gas, and in order to do that, for the gas to spread and press against the epithelium, the pigmental epithelium, we positioned our patient in prone position so that the area was flattened and the power of tension was rising. And we've had a couple of cases. I hope that Taras Bogdanovich will soon publish his work about dynamics of development without anti-VEGF therapy, just with administration of gas. As you may see here, it's before pneumoretinalexy, 5 days afterwards, when the tension was decreased. So at this point, anti-VEGF therapy can be used with minimal risk. I'm grateful for your attention. Don't despair, even in those cases which look really complicated.
Thank you very much. Today we have a very optimistic day, and we have a lot of options. Complicated patients, complicated cases. Your questions? Do the methods of drop of fourth stage described in literature? No, I haven't met such information in literature. There was an information on transplantation, but for now I haven't seen such a publications. How much gas do you inject? As for pneumodislocation, up to 0.5 is if an eye is amyotropic. What about hypertension? Of course, we have it, but we control it on our operational table, the pulse of retina. If we don't have it, we perform photosynthesis. So we decrease the pressure, and we are sure that we have a light sensitivity just during the surgery. I can add some patients with a 4-stage of TE. Of course, there are non-common information, but I see the migration of pigment epithelium cells, and this zone changes from time to time. Of course, it's not monthly changes, they take place during 1 or 2 years. Of course, there are some substitutions and some cells migrate there. I can say that it improves the vision of patient, but still we have such a process, and we have a discussion 10 or 15 years ago. So we can't struggle against pigment epithelium, unfortunately. Uh, when we had peripheral degeneration, I tried to do it, um, but still, when VMD-like process in on peripheral retina, but I took away a hemophthalm and saw blood and saw this tensed epithelium. So it was damaged by me. I wanted to put it into the place, but it's like an ash. It is very unstable. You can't take it and put into the place where you need. It is a very unstable structure, fragile structure. We have the third report. It is a pre-recorded report, so please. Oleg Parhomenko, candidate of medical sciences, bilateral injection of which anti-VEGF therapies in patients with retinal diseases. Good day, dear colleagues. Andrei Rostislavich, Mikola Rostislavich, we will talk with you about bilateral injection of aflibercept in patients with retinal disease. First intravitreal injection was done more than 100 years ago in 1911 to prevent retina detachment. Now it is widely used practice when we have extrudative retina diseases. By 2025, there are more than 50 million intravitreal injections made all over the world. Uh, this number has increased by 500%. That tells us about high interest and high request in this field. Um, Near all 80% of intravitreal injections are of anti-VEGF medications. As to the global prof insight, April of this year, 2025. What about future tendencies, technologies, innovations, graft manufacturing? We can reduce the frequency of injections by 30-50%, but these grafts, we don't have such a grafts. AI will help in diagnostics, so will improve the establishing diagnosis of retinal diseases on early stage by 30%. So intravitreal injections are key method in treatment of retinal diseases. And of course, administration of medication and way of administration is the key element that make it winner. Now we will see with you the procedure of intravitreal injection in our clinics and what are the world recommendations. The technique of intravitreal injection in our clinic, it's the treatment of operational field with spirits or iodine, because it helps us to prevent endophthalmitis. That's why we use those medications to isolate my bona duct. Then we measure 4 millimeters for phakic eye and 3.5 for aphakic eye. And after the injection, we use needles 29-30. We inject in the center of video's body or in the center of eyeball as to the instruction, and compression in the place of injection. And we check the profusion of central arterium of choroidis of retina. There is a world consensus published in Ophthalmological Journal. It's a consensus of your retina dated by 1218. Local anesthesia. No recommendations what medication we should choose, and povidone iodine prevails. Antibiotics are not recommended. As to our legislation, we should use antibacterial medication and inflammation medication. Maybe we should dilate the pupil, but it is not mandatory. It helps us to examine the central veins and central veins of retina. 30 DH needle. The needle should be flexible. Pars plana distance is 3.54 millimeters. In Ukrainian order, we have it for eyes with a high part of anterior part of eye. Bilateral injections are recommended as a separate procedures. Every injection is a separate procedure. Let's talk about recommendations. Gloves are recommended. Patient is not recommended as mandatory. VG of Academy, it's a very powerful organization. They have their own recommendations, and as to them, if you follow procedures and precautions, you will reach the success. And there is a mandatory procedure. Medications should be from different series, but in our country it is not possible because when we have a supply of efimosumab, for example, we have some pauses in this supply. So that is why in our practice we use preparation from different flasks. Patients who are firstly injected needs higher attention. There are also recommendations on Bioretina Expert Association and recommendation of the Queen College of Ophthalmologists. As to those recommendations, bilateral injections in the same day is a widespread procedure within the world. It is not forbidden if there are no other indications in instruction. Every other injection should be done as separate procedure, and we should make it with the different devices. We change our clothes, we change covers, and of course we change instruments. Sometimes if you have to operation surgery room, you can change them as well. And our surgeons also wash each time. And we take different flasks of medication. All are interested about the consequences because a lot of people know about the stories about inflammations and different complications. As to the scientific publications, mm, published in 2023, patients with neovascular and vascular proliferation who took injections in 23 months bilaterally in one and the same day compared uh, to the injection in different days. We see that it is widespread practice and the amount of side effects is very wide. Frequency of side effects was the same in both groups. And surgeons want to make injections in one and the same day. They like this procedure. There is no additional discomfort for patients. In our practice, we recommend to examine patients the next day. We don't do bilateral injections during the first visit of patients. We start injections um, separately, each eye separately, but when we have a positive results, we continue bilateral injections performing in one and the same day. And also patients want to be injected in one and the same day. What about complications? The need or request to visit ophthalmologists after the injections in an urgent way needs only 37% of patients. We have blur vision. Then we have different splashes, cornea erosion, and also we have subretinal hemorrhage, and we have to observe those issues. They will be resolved by themselves without additional interventions. The procedure considered to be safe. Immunogenicity of this procedure, we should pay attention to this aspect because as to our experience that we had during these injections, we had such a specific complication as vasculitis, and it looks like endophthalmitis very often. There is an opacity and then worsening of vision. It looks like ophthalmitis very often, and patients don't like the result. They don't reach their goal, but in many cases, vasculitis and autoimmune cataracts are treatable, and patients get the pre-operative level of vision in 3-6 months. But during this period, there is an additional stress and additional efforts both of surgeon and patient. So that's why we, in our practice, we prefer aflibercept. Why? Because it doesn't have immunogenicity, and it's considered to be safe as to the studies conducted. Aflibercept is a world leader of anti-VEGF therapy with more than 70 million of injections in more than 100 countries in the world. The profile of intraocular safety and eye safety was positive. Monitoring results were also positive. Systematic absorption is also very crucial sign. So its influence on systemic organs and systems is also very crucial, and we have this data with aflibercept, because another anti-VEGF medications, it is not recommended to inject medication more often than in 28 years. If we are talking about aflibercept, we don't have such a data. And it is the most safe medication. So let's present you a clinical case when we recommend you to make repeated injections, when there are indications, for example, when patient is not able to come very often. Now the situation is very relevant. Patient 77 years, new vascular age degeneration of both eyes, intraretinal, subretinal hemorrhage in both eyes. He has been treated for a long time. Inject OD visual acuity 0.01, and it is a supportive dose. These patient gets supportive doses of medication once a year. What about OC? There were performed more than 70 injections of different anti-VEGF preparations. Visual acuity is 0.07. He feels the recurrence of edema, and he visits us to make a control. Here you can see standard supportive injection before and after the procedure. You can see it on the image and the absorption of liquid. He performs to install special drainage, and then he visited us with the OC decrease in visual acuity, and we can see here the detachment of retina. There is a reactivation of membrane with intraretinal hemorrhages on OD. Patient is not able to visit us in different days. He lives far from Kiev. He was recommended bilateral aflibercept injection, and we performed it in one day. He recommended a visit the next day, but he contacted us and said that the situation was okay. We understood that he would get the preparation of anticoagulants, and we prepared him for the future surgery. Thank you very much for your attention.
There are some questions probably. Good day once again. So please tell us, we have understood about the bilateral injections, but what do we have to do with the patient's position? Lately, I have been doing my injections with my patient sitting. What do you think about injections not in the lying, not in the prone position? Is it safer if the patient sits? In our opinion, it doesn't matter if the patient is lying or sitting. However, we took part in one research about intravitreal injections, and at certain time, some researchers shared that intravitreal injections in their patients had no complaints about the performance in lying position, and they said that they changed the protocol somehow because the patient in that case had been lying for 10 or 15 minutes prior to the injection, and they were trying to observe what happened with the liquid, with the injection, with the preparation, if its spreading was more balanced and regular. So this is what they told me. Just the patient has to lie about 15 minutes on the table before the injection. I think that, but in our opinion, the position of the patient does not matter so much. The main thing is that the injections do not have to take place in one and the same point. We don't want any complications in form of thinning of sclera, for example. Yes, thank you very much. It's just that when we were studying in Bono clinics with Stanislav Gennadievich Saksonov and Frank Holtz, who is a famous specialist and a wonderful vitreoretinal surgeon, he had done a research about intravitreal administration of ranibizumab when he had a queue of patients sitting and expecting him somewhere in the hall, and he just quickly performed all the injections in turns to one after another patient, and everything went really well in the sitting position. So thank you once again. Thank you, and I'm sure we will meet soon in person, and I would like to thank everyone who attended this wonderful satellite meeting, and I would like to award the official representative of Bayer company this gratitude certificate, and I hope that we will cooperate soon. We are going to have some coffee break now. We are going to have this break before.
Світ без хвороб та голоду. Такою є місія компанії Bayer. Це прагнення, яке поділяють наші працівники по всьому світу. З перших днів повномасштабного вторгнення компанія передає Міністерству охорони здоров'я ліки та медичні матеріали для десятків тисяч пацієнтів. Було профінансовано закупівлю 6 карет швидкої допомоги для лікарень та бригад екстреної допомоги Червоного Хреста України. Крім того, 44 дефібрилятори встановлено на вокзалах, станціях метро та в лікарнях у 18 областях України. Компанія виділила 1,3 мільйона євро для відбудови української інфраструктури у сфері охорони здоров'я через фандрейзингову платформу United24 для ремонту Чернігівського медичного центру сучасної онкології та придбання обладнання для Інституту нейрохірургії імені Ромоданова. Спільно із благодійним фондом Дон Калабрія компанія надає психологічну підтримку близько 3 тисячам внутрішньо переміщених дітей та їхніх батьків допомагаючи подолати симптоми посттравматичного стресового розладу. Через агресію проти України продовольчу кризу відчула частина населення світу. Небезпека голоду стає ще більшою, і ми робимо все, що в наших силах, аби їй протидіяти та підтримати аграріїв України. Наразі однією із найбільших проблем для українських аграріїв є велика кількість мін та боєприпасів,